there, and welcome back to the deep dive.
Hello.
Today, we're diving into the incredible systems that let us experience the world, maintain our internal balance, and even restore ourselves each night.
Yeah, we're talking pain, temperature, sleep, and our amazing senses. It's quite a lot to cover.
It really is, and it's truly a foundational look at how we function.
Right. And we're pulling all our insights today from Chapter 15 of Understanding Pathophysiology, 7th edition, by Huether, Brashers, and Rote.
That's the one. Our mission today is to, cut through the complexity, give you the essential nuggets of knowledge.
Exactly. So by the end, you'll hopefully have a much clearer picture of what's happening behind the scenes.
When you feel a prick, shiver in the cold, dream, or simply see and hear, it's time to unpack some truly remarkable biology. Okay, let's kick things off with pain. It's something we all know, but it's far more complex than just a simple ouch.
Oh, definitely.
Our source gives us a definition that goes beyond just a physical feeling, doesn't it?
It does, and this is crucial. The International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience.
Yeah.
Associated with actual or potential tissue damage.
Sensory and emotional. That's key.
Absolutely. What's striking is that it's not just physical, it's a dynamic interplay. Physical, cognitive, emotional, even environmental factors all play a part.
Which explains why it feels so different for everyone.
Precisely. It's deeply subjective.
Yeah.
And acute pain, like touching a hot stove, that's protective. It's your body's urgent alarm system.
Teaching you to pull back fast.
Exactly. Avoid further harm.
So when we say stub a toe, what's the actual pathway this ouch signal takes through our body? How does that work?
Well, think of it like an emergency call system. It travels through three main parts of your nervous system.
Oh.
First, you've got the afferent pathways. These are like the sensors, picking up the initial fire in your peripheral nerves.
Out in the body.
Right.
Yeah.
Then they relay that signal through your spinal cord, specifically the dorsal horn, and then up to the brain.
Got it. Step one. What's next?
Step two is the interpretive centers. These are various networks in your brain, brainstem, cortex. This is where that signal is finally understood as pain.
Where you realize, that hurts.
Pretty much. And third, there are the efferent pathways. These are signals descending back down from the brain to the spinal cord.
Going the other way. Why?
To influence how your body responds to that pain. Maybe pulling away, maybe tensing up.
Makes sense. And what about the actual pain receptors, the things that initially pick up that signal?
Those are called nociceptors. They're specialized free nerve endings found pretty much all over your body.
Specialized how?
They're like highly sensitive alarm bells that only ring when there's actual or potential harm. That process is called nociception.
So not just any touch triggers them.
No, exactly. They respond to specific things. Mechanical stimuli like intense pressure, thermal extremes, think burning or freezing, or chemical triggers.
Like inflammation stuff?
Right, substances released during injury. And what's interesting is they're not evenly distributed. Your skin is packed with them, very sensitive.
Makes sense.
But some internal organs have fewer. That's why, internal pain can sometimes be harder to pinpoint.
Yeah, like a vague ache versus a sharp cut.
Exactly. Our source actually contrasts that, like stomach pain from distension versus a skin prick. Very different sensations.
Okay, so from that initial alarm bell ringing, what are the steps? How does that become the feeling of pain we consciously recognize?
Right, so nociception itself involves 4 distinct phases. Think of it like stages of an emergency response.
Okay. Phase 1.
Transduction. This is the initial spark. The harmful stimulus directly activates those nociceptors, creating an electrical impulse.
The signal is generated.
Correct. Phase 2 is transmission. That impulse then races along specific nerve fibers. Imagine 2 main types of phone lines for this emergency call.
Okay, different lines.
Yep. You have A delta, say fibers. These are like super fast myelinated lines. They carry fast pings.
Fast.
Sharp, well-localized alerts, like a pinprick. They're so quick, they can trigger a reflex withdrawal before you even consciously feel the pain.
Wow. Pull your hand away before you even think hot.
Exactly. Then you have C fibers. These are the slower, unmyelinated lines, more numerous actually.
And what kind of pain do they carry?
They transmit slow pain, dull, aching, or burning sensations, often poorly localized, maybe more constant.
Got it. Fast and sharp, slow and dull.
Right. And these signals travel up to your spinal cord, they cross over to the other side, and then ascend to your brain for interpretation. Areas like the somatosensory cortex get involved.
Okay, so that's transduction and transmission. What's next?
Phase 3, perception. This is when your brain consciously registers the pain. It's not just about where it hurts or how intense it is.
There's more to it.
Oh yeah, it includes your emotional response, what you've learned from past experiences, your genetics, culture, age, even your current mood can significantly color this perception.
So my pain isn't necessarily your pain, even from the same injury.
Precisely. And finally, phase 4, modulation. And this is truly remarkable.
Modulation.
This is where your nervous system can literally turn the volume up or down on that pain signal.
Ah, okay, this is where it gets really interesting. Our body has a built-in volume control for pain. How does that work?
It does. Pain modulation is incredibly complex.
Yeah.
It involves a whole symphony of neurotransmitters and pathways. Think of your brain as having its own internal pharmacy.
Okay.
So you have excitatory neurotransmitters, things like prostaglandins released during injury or glutamate in the brain.
Yeah.
These can sensitize nociceptors, make them more responsive, turn the volume up.
Making things feel more painful.
Right. But then you have inhibitory neurotransmitters like GABA and glycine, which can suppress pain signals, turn the volume down.
Okay, so chemicals that increase it, chemicals that decrease it.
Exactly. And here's the real wow factor.
Yeah.
Your body produces its own natural painkillers. They're called endogenous opioids.
Endogenous, meaning from within, like endorphins.
Precisely. Endorphins, enkephalins, dynorphins. They're chemically similar to morphine, actually.
Yeah.
They bind to specific opioid receptors in your nervous system and inhibit the transmission of pain impulses. Our source has a figure showing this. Imagine impulse coming down from your brain.
Oh,
It stimulates a nerve cell, an inner neuron, in your spinal cord to release these endorphins. And those endorphins then put the brakes on the pain signal right there before it even gets high up in the brain.
that's incredible. So our bodies really do have this internal pain relief system.
They do. And there are other players too, like endocannabinoids, similar idea, acting on different receptors to modulate pain.
So beyond the chemistry, are there other ways our body modulates pain? Like, I bang my elbow and then instinctively rub it. Does that actually do anything?
Absolutely. That's a great example of segmental pain inhibition.
Segmental, meaning at the same level.
Yes, at the same spinal cord level. When you rub your elbow, you stimulate large, fast-touch fibers. Those are called A-beta fibers,
Okay.
different from the pain fibers.
Yeah.
Right. And stimulating those fast-touch fibers can actually inhibit the pain transmission coming from the slower A-delta or C fibers nearby. It's part of the famous gate control theory of pain.
So rubbing it literally helps close the gate on the pain signal.
In a way, yes. Our source also mentions something called diffuse noxious inhibitory control, or DNIC.
What's that?
It's where pain from one area of your body can actually inhibit pain from another distant area. It's complex, but it's thought to be the basis for why things like acupuncture or deep massage can relieve pain.
Fascinating. And what about the mind's role, like when we brace ourselves for pain or expect it?
That leads us to expectancy-related cortical activation. This is where your cognitive expectations can cause real physiological changes that impact pain.
You mean like the placebo effect?
Exactly. That's the placebo effect when beneficial expectations lead to improvement. Or the opposite, the nocebo effect, where negative expectations can actually worsen symptoms or create them. Your belief can genuinely alter your physical experience.
The brain is powerful. Now, obviously, pain feels different to different people and at different times.
Absolutely. The source differentiates between pain threshold, that's the lowest intensity of pain you can recognize,
Okay, the minimum level.
and pain tolerance, the greatest intensity of pain you can endure.
How much you can handle.
Right. And both are highly subjective, influenced by genetics, culture, fatigue, mood, even your beliefs. And age plays a role too. Infants tend to be more sensitive, while older adults might have a higher threshold, but varied responses overall.
So, given all this complexity, how do doctors talk about different kinds of pain? How do they categorize it?
Well, the chapter outlines several key clinical descriptions. First, there's acute pain.
The short-term kind.
Right. Transient, usually lasting up to 3 months. It's your protective alarm signaling immediate harm, and it can be. Somatic pain,
Somatic.
from skin, joints, muscles, like a sharp cut or a dull muscle ache. It's usually pretty well localized. Then there's visceral pain. That's from internal organs. Think gallstones or appendicitis. It's often poorly localized, more like an aching or cramping feeling. Can come with nausea, too.
Makes sense. Organs are deeper, harder to pinpoint.
Exactly. And then there's referred pain. This is a really interesting one.
Here you feel it somewhere else.
Precisely. Pain is felt in an area distant from its actual origin. But crucially, both areas share nerve pathways from the same spinal segment.
Like the classic heart attack pain in the left arm.
That's the perfect example. Our source has a diagram showing this. The heart problem triggers signals that travel along nerves shared by the arm and shoulder area for interpretation. So your brain thinks the pain is coming from the arm. The diaphragm might refer pain to the shoulder too.
Wild. Okay, so that's acute pain. What else?
Then there's chronic pain. This lasts longer than 3 to 6 months. And unlike acute pain, it really serves no protective purpose.
It just persists.
Right. It often feels out of proportion to any observable injury. And it can profoundly impact a person's life, leading to depression, sleep problems, changes in behavior. The body can adapt physiologically too, sometimes masking outward signs of pain even though the person is suffering.
What are some examples?
Oh, things like persistent low back pain, myofascial pain syndromes, some types of cancer pain, phantom limb pain after an amputation.
Yeah.
It's a major health issue.
And finally,
There's neuropathic pain. This is chronic pain caused by a lesion or dysfunction within the nervous system itself. Nerve damage.
so the nerves themselves are the problem.
Exactly. It's often described very differently: burning, shooting, tingling, electric shocks. And you might get allodynia.
Allodynia.
Yeah, that's experiencing pain from stimuli that normally wouldn't cause pain, like a light touch from clothing suddenly feeling intensely painful.
Ouch.
It could be peripheral, like nerve entrapment in carpal tunnel, or central, from brain or spinal cord injuries.
Okay, moving from pain, our body's urgent alert system, let's talk about something just as vital, but maybe more subtle, maintaining our internal temperature.
Ah, yes, thermoregulation.
Yeah.
Keeping everything in that Goldilocks zone.
Exactly. It's like we have this incredibly precise internal thermostat. How does our body manage that, keeping us stable even when outside temperatures swing wildly?
It's amazing, isn't it? Our core body temperature is incredibly precise, normally hovering between 36.2 degrees and 37.7 degrees Celsius. That's about 96.2 degrees to 99.4 degrees Fahrenheit.
A very narrow range.
Very. And this regulation, thermoregulation, is primarily orchestrated by the hypothalamus in your brain.
The control center again?
Yep. It acts like the central thermostat, constantly getting updates from temperature sensors, thermoreceptors located throughout your body, in your skin, liver, muscles, even within the hypothalamus itself.
So what are the basic tools it uses? How does the body actually generate heat or get rid of it?
Okay, so heat production comes mainly from metabolic processes, chemical reactions, digesting food, and skeletal muscle activity. Even just slight increases in muscle tone generate heat.
And shivering, obviously.
Right. Shivering is maximal heat production from muscles.
Mm.
When your body needs to warm up, the hypothalamus triggers things like increasing your metabolic rate hormones like thyroxine get involved, and activating brown fat, especially in infants, which burns energy specifically for heat.
And to keep the heat in.
For heat conservation, it initiates vasoconstriction, tightening blood vessels near the skin surface to shunt blood towards your core, keeping vital organs warm. And of course, shivering involuntary actions like putting on a jumper.
Makes sense. So how do we cool down?
When it's too warm, the hypothalamus reverses those mechanisms. We lose heat primarily through 4 ways.
Okay.
Radiation, just heat radiating off your skin into cooler surroundings.
Yeah.
Conduction, direct heat transfer if you touch something cooler. Convection, heat carried away by moving air or water, like a breeze.
It's like standing in front of a fan.
Exactly. And importantly, vasodilation.
Opening up the blood vessels near the skin.
Right, diverting warm blood to the surface to maximize heat loss, and of course evaporation, primarily through sweating. As sweat evaporates, it takes heat with it, cooling you down significantly.
Sweating is key then.
Absolutely.
Okay.
Our source has a nice table summarizing all these production and loss mechanisms.
Now, you mentioned infants earlier. It seems like infants and also elderly people often struggle with temperature regulation. Why is that?
They do, and it really highlights how finely tuned this system is. Infants, especially premature ones, can produce heat from their brown fat, but they lose it very easily.
Why?
They have much higher body surface area relative to their weight and less insulating subcutaneous fat. Plus, crucially, they can't shiver effectively to generate heat.
Ah, okay. And the elderly?
Elderly persons often face the opposite challenge, responding poorly to both heat and cold. Their circulation might be slower, their skin thinner, they tend to be less active, which means less metabolic heat production, and their ability to shiver or sweat efficiently is often reduced.
So more vulnerable at both extremes.
Generally, yes.
Now, here's a really interesting point you touched on earlier. Fever. We often think of it as purely negative, something to get rid of quickly. But our source suggests a moderate fever actually has benefits. Can you explain that?
Yeah, this is a critical point. Is fever really the enemy we often think it is? Fever, or the febrile response, isn't just uncontrolled overheating. It's a temporary resetting of the hypothalamic thermostat to a higher level.
So the body intends to be hotter.
Exactly. It's a deliberate strategic defense mechanism. When your body encounters things called pyrogens.
Pyrogens, fire makers.
Sort of. They can be exogenous, like toxins from bacteria, or endogenous, like cytokines released by your own immune cells. These pyrogens stimulate your hypothalamus to produce prostaglandin E2, or PGE2.
Okay.
And that PGE2 is what actually raises the thermostat set point. Your body then actively works to reach this new, higher temperature. That's why you feel cold, shiver, and want to bundle up, even though your core temperature is rising.
Because your body thinks it should be warmer than it is.
Precisely. Our source has a figure illustrating this whole cascade, and it points out several benefits of this raised temperature.
Like what?
Well, a higher temperature can directly kill or inhibit the growth of many microorganisms. It also reduces the levels of minerals like iron and zinc in the blood, which bacteria need to replicate.
Taking away their food source.
In a way, it can also cause lysosomal breakdown within infected cells, which helps prevent viruses from replicating. And it generally enhances immune responses, like phagocytosis, the process where immune cells engulf invaders.
So a moderate fever is often a sign your body is fighting back effectively.
Often, yes. Of course, very high fevers can be dangerous, and you need caution, especially in young children or the elderly who might have atypical responses. But automatically suppressing every low-grade fever might not always be the best strategy.
Interesting perspective, but what happens when that thermostat totally malfunctions, when it's not a controlled response?
Right, that's when we get into serious trouble. We see two main types of disorders here. First, hyperthermia.
Hyperheight, thermia, temperature, too hot.
Exactly. But crucially, this is an elevation of body temperature without an increase in the hypothalamic set point.
Yeah.
Your body is just overheating, and the thermostat hasn't been reset higher.
So the body knows it's too hot but can't cool down.
Or the heat gain simply overwhelms its ability to lose heat. This can cause nerve damage, protein coagulation. It's dangerous. We see forms like heat cramps, heat exhaustion, and the most severe, heat stroke.
Heat stroke is the really bad one, right?
Yes. That's where the thermoregulatory center itself fails. The core temperature can soar to very high levels, and a key sign is often a lack of sweating, along with confusion, coma. It's a medical emergency.
Okay. And the other type?
There's also malignant hyperthermia. This is a rare inherited condition triggered by certain anesthetics. It causes uncontrolled hypermetabolism, muscle rigidity, and a rapid, dangerous spike in temperature.
Wow, scary. And the opposite of hyperthermia?
That's hypothermia, hypo-low-low. When the core body temperature drops below 35 degrees Celsius or 95 degrees Fahrenheit.
Too cool.
Right. This depresses your central nervous system and respiratory system. It causes intense vasoconstriction to try and conserve heat, but that can lead to frostbite or ischemic tissue damage in the extremities.
Mostly happens from cold exposure.
That's accidental hypothermia, yes. But interestingly, therapeutic hypothermia is also used medically.
Cooling people down on purpose.
Yes. Sometimes after cardiac arrest or during certain surgeries, carefully controlled cooling can slow metabolism and protect tissues from damage due to lack of oxygen.
Fascinating how we can manipulate these systems. Okay, let's shift gears now to another vital process, sleep. We spend about a third of our lives doing it, but why is it so incredibly important? How does our body actually manage it?
Sleep is far from just switching off. It's an active, really complex, multi-phase process. It's absolutely crucial for restorative functions, repairing tissues, clearing out metabolic waste from the brain, and also for things like memory consolidation.
Locking in what we learned during the day.
Exactly. And it's all governed by intricate neural circuits, hormones, neurotransmitters, all tightly coordinated with our circadian rhythms.
Our internal 24-hour clock.
Right, that natural cycle of sleepiness and wakefulness.
Now, I've heard a lot about REM and non-REM sleep. What's the core difference between those two main states?
Our source breaks sleep down into these two primary phases. First, you have non-REM sleep. This actually makes up the bulk of your sleep time, around 75% to 80%.
Okay. What happens during non-REM?
This is generally where your body winds down. Your sympathetic nervous system activity decreases, your basal metabolic rate falls, muscles relax, and importantly, growth hormone is released, especially in the deeper stages. It progresses through 3 stages, from light dozing to very deep restorative sleep.
Stage 3 is the deep sleep.
Right. Then you cycle into REM sleep. That's about 20% to 25% of your total sleep time.
REM, rapid eye movement.
Exactly. And it's often called paradoxical sleep.
Paradoxical. Why?
Because your brain activity, if you look at an EEG, actually looks very similar to when you're awake. It's highly active.
Huh.
And this is the stage where most vivid dreaming occurs. REM sleep is thought to be vital for memory consolidation, emotional processing. Your parasympathetic system is more active, but you also get bursts of sympathetic activity. And crucially, your major muscles are temporarily paralyzed,
Paralyzed. Why?
probably to stop you from physically acting out those vivid dreams.
Makes sense. Okay, so we cycle between non-REM and REM throughout the night. Do these patterns stay the same across our lifespan?
No, they change quite significantly with age.
How so?
Well, infants, for example, sleep a lot, maybe 10 to 16 hours a day, and about half of that sleep is REM sleep, which is way more than adults. Their sleep cycles are also shorter.
Interesting.
By around ages 3 to 5, children generally adopt more adult-like sleep patterns. But then as people get older, especially in elderly persons, sleep patterns tend to change again.
How? Less sleep.
Often, yes. Total sleep time might decrease, it might take longer to fall asleep, and they tend to spend less time in that deep, restorative stage 3 non-REM sleep. They also might wake up more frequently during the night.
And that can cause problems.
Absolutely. These age-related changes can increase the risk for sleep disorders and definitely impact daytime function and overall well-being. Our source has a box summarizing these age-related changes.
So when that active restorative process goes wrong, what are some of the most common sleep disorders we see?
Sleep disorders are broadly classified into two main groups. First, the dysomnias.
Dysomnias.
These are problems with initiating or maintaining sleep, or problems with excessive sleepiness.
Okay, what falls under that?
The most well-known is probably insomnia. Basically, the inability to fall asleep, stay asleep, or having non-restorative sleep, which then affects your daytime performance. It can be transient, maybe due to stress or jet lag, or chronic, often linked to things like pain, depression, or lifestyle factors.
Very common. What else?
Then there's obstructive sleep apnea syndrome, or OSAS. This is actually the most commonly diagnosed sleep disorder.
Sleep apnea. That's when breathing stops during sleep.
Yes, repeatedly. Your upper airway gets partially or totally blocked during sleep. This leads to loud snoring, gasping for air, and brief periods where breathing stops, completely apneic episodes.
Who's most at risk?
Major risk factors include obesity, getting older, and being male, though women can certainly have it too. If it's untreated, OSAS can lead to serious health problems like high blood pressure, heart issues, even stroke.
Scary stuff. Any other dysomnias?
Yes, hypersomnia, which is excessive daytime sleepiness. Often this is linked to underlying conditions like OSAS, but it poses its own risks, like falling asleep while driving. Then there's narcolepsy.
I've heard of that. Isn't that falling asleep suddenly?
It's characterized by overwhelming daytime sleepiness and sleep attacks, but also other symptoms like disruptions in the sleep-wake cycle, sometimes hallucinations as you fall asleep or wake up, sleep paralysis, and sometimes cataplexy.
Cataplexy.
That's a sudden, brief loss of muscle tone, often triggered by strong emotions like laughter or surprise.
Wow.
And finally, under dysomnias, we have circadian rhythm sleep disorders. This is when your internal body clock is out of sync with the external environment. Think jet lag or shift work sleep disorder. Working irregular hours can really mess with your internal clock and has been linked to long-term health risks.
Right, messing with that natural rhythm. Okay, so those are dysomnias. What's the other category?
And parasomnias. These are unusual behaviors that occur during sleep or during the transition between sleep and wakefulness.
Like sleepwalking.
Exactly. Sleepwalking, somnambulism, and night terrors are common parasomnias, especially in children. They typically occur during deep non-REM sleep, stage 3, and often resolve on their own.
Okay, what else?
A really common one is restless leg syndrome, or RLS, also known as Willis-Ekman disease.
RLS, that's the creepy, crawly feeling in the legs.
Yes, people describe unpleasant sensations, crawling, prickling, tingling in their legs, usually worse in the evening or at night when resting. And it comes with an almost irresistible urge to move the legs to relieve the sensation. It can severely disrupt sleep onset and maintenance.
That sounds awful.
It can be very distressing. Then there's REM sleep behavior disorder, or RBD. Remember how we said muscles are normally paralyzed during REM sleep?
Right, to stop acting out dreams.
In RBD, that paralysis is lost or incomplete. So individuals physically act out their often vivid and sometimes violent dreams. They might thrash, punch, kick, even jump out of bed, potentially injuring themselves or their bed partner.
Wow.
And importantly, RBD can sometimes be an early prodromal sign of neurodegenerative diseases like Parkinson's disease.
Okay, moving on from sleep, let's explore our special senses: vision, hearing, smell, taste, these incredible systems that truly connect us to the world around us. Let's start with the dominant one for many of us: vision.
Absolutely. The eye is just an incredibly sophisticated biological camera. It has three main
Okay,
layers.
layer one.
The outermost tough, white layer is the sclera. At the very front, it becomes transparent as the cornea, which lets light enter and does a lot of the initial focusing.
The window of the eye.
Exactly. Layer 2, the middle layer, is the choroid. It's pigmented, contains blood vessels, and includes the iris.
The colored part.
Right, the iris acts like the diaphragm of a camera, controlling the size of the pupil to regulate how much light gets in.
Makes sense. And layer three.
The innermost layer is the retina. This is the light-sensitive film of the eye. It contains millions of photoreceptor cells.
Rods.
Rods are for dim light vision and peripheral vision. They detect black, white, and gray. And then cones.
Cones for color.
Yes, cones are for color vision and sharp detail, especially in bright light. They're most densely packed in a central area called the fovea centralis, which is where your visual acuity, your sharpest vision, is highest. This is where light energy gets converted into nerve impulses.
Pretty amazing. What about the lens?
The lens sits behind the iris and pupil. It acts like the fine-tuning focus mechanism of your camera. It can change shape, becoming thicker or thinner through a process called accommodation, to focus light precisely onto the retina, whether you're looking at something near or far.
And how does the signal get from the retina to the brain?
Those nerve impulses generated by the rods and cones travel via the optic nerve, which exits the back of the eye. The two optic nerves meet at the optic chiasm.
The crossing point.
Right. At the chiasm, fibers from the inner half of each retina cross over to the opposite side of the brain, while fibers from the outer half stay on the same side. These pathways then continue to the visual cortex in the occipital lobe, where the signals are interpreted as images.
That crossing explains why damage in certain places causes specific vision loss patterns, right?
Right.
Like losing vision on one side.
Exactly. Our source has a figure showing how damage at the optic nerve, the chiasm, or further back, leads to predictable visual field defects.
So what are some of the most common ways this remarkable visual system can go wrong?
Well, there are many potential issues. We can group them. First, alterations in ocular movements.
Eye movements.
Right. Things like strabismus, where the eyes don't align properly. One eye might turn inwards, outwards, up or down. This can cause diplopia, or double vision. In children, if it's not corrected, it can lead to amblyopia, or lazy eye, where the brain starts to ignore the input from the deviating eye.
Okay. What else affects movement?
Nystagmus, which is involuntary, rhythmic, back and forth movement of the eyes, or paralysis of the muscles that move the eyeballs.
Got it. What's another category?
Alterations in visual acuity, basically, how
Yeah.
clearly you can see. Sharpness of vision. This naturally tends to decline somewhat with age. But major disorders include
Cataracts.
cloudy lenses. Right.
Exactly. A cloudy or opaque area develops in the lens, scattering light. It's the leading cause of blindness worldwide. Causes decreased acuity, blurred vision, problems with glare.
Very common, especially in older adults. Yes. Then there's glaucoma. This is the second leading cause of blindness. It's characterized by increased pressure inside the eye, intraocular pressure, which damages the optic nerve over time, leading to gradual loss of peripheral vision first.
Often called the sneak thief of sight.
It is, because the central vision loss happens later. There's also an acute form, angle closure glaucoma, which is a medical emergency, and age-related macular degeneration, or AMD.
Affecting the macula, the central part of the retina.
Right, specifically the fovea. It causes irreversible loss of central vision, making reading, recognizing faces, driving difficult or impossible. It's a major cause of blindness in older individuals in developed countries. There are dry and wet forms.
Okay, acuity issues. What else?
Alterations in accommodation. Yeah, it's the lens losing its ability to change shape to focus up close. The age-related form is called presbyopia.
Needing reading glasses after 40.
That's presbyopia, very common. And then alterations in refraction. These are issues with how the eye focuses light even before accommodation. Very common too.
Like being nearsighted or farsighted.
Exactly. Myopia is nearsightedness. You see near objects clearly, but distant objects are blurry because the light focuses in front of the retina. Hyperopia is farsightedness. Distant objects might be clear, but near objects are blurry because the focus point is technically behind the retina. And astigmatism is when the cornea is unevenly curved, like a football instead of a basketball, causing light to focus unevenly, blurring vision at all distances.
Makes sense. What about color vision?
Alterations in color vision can happen. It can diminish somewhat with age, partly due to the lens yellowing, which can affect perception of blues and greens. More commonly known is congenital color blindness, which is usually an X-linked inherited trait, meaning it affects men much more often than women. Red-green color blindness is the most common type.
Got it. And what about problems with the external parts of the eye, like infections?
Those are also very common. The eyelids, conjunctiva, they protect the eye. Conjunctivitis, or pink eye, is an inflammation of the conjunctiva, the thin membrane covering the white part of the eye and inner eyelids. It can be bacterial, viral, often highly contagious or allergic.
Pretty common, especially among kids.
Very. And critically, the source mentions trachoma. This is a specific type of conjunctivitis caused by chlamydia trachomatis. It's the leading cause of preventable blindness globally, often spread in areas with poor sanitation and hygiene. Repeated infections cause scarring that turns the eyelashes inward, scraping the cornea.
Terrible. Preventable blindness.
Yes, and keratitis is an infection or inflammation of the cornea itself. That's serious because it can lead to ulceration, scarring, and significant vision loss.
That's a lot to take in for vision. Let's switch senses now. Hearing and balance, they're linked in the ear, right? How does our ear manage both capturing sound and helping us stay upright?
It's a marvel of engineering, really. The ear has three main sections. The external ear, the pinna, the part you see, and the auditory canal funnels sound waves towards the tympanic membrane, or eardrum.
Making the eardrum vibrate.
Right. Those vibrations are then transmitted through the middle ear. This is an air-filled cavity containing three tiny bones, the ossicles, the malleus hammer in Ixisix anvil, and stapes stirrup. They act like a lever system, amplifying the vibrations.
Tiny bones doing a big job.
Absolutely. The stapes then presses onto the oval window, an opening into the inner ear. This sets the fluids within the inner ear in motion. The middle ear also contains the eustachian tube, which connects to the back of your throat and helps equalize pressure on either side of the eardrum.
Like when your ears pop on a plane.
Exactly. That's the eustachian tube working. Then we get to the inner ear. This is where the magic happens for both hearing and balance.
Okay. Hearing first.
For hearing, there's the cochlea, which looks like a snail shell. It's filled with fluid, and running through it is the organ of Corti. This contains specialized hair cells. When the fluid moves due to the stapes vibrating, these hair cells bend.
And that's the signal.
Yes. The bending of hair cells converts the mechanical energy of the fluid waves into electrical nerve impulses. These impulses travel along the auditory nerve to the brain, where they're interpreted as sound, pitch, loudness, location.
Amazing. And balance. How does that work in the inner ear?
For balance, or equilibrium, there are two main parts. The semicircular canals, three fluid-filled loops oriented in different planes. When your head moves, the fluid inside these canals lags slightly due to inertia, bending hair cells within them. This tells your brain about rotational or angular movement's dynamic equilibrium.
Like spinning around.
Exactly. Then there's the vestibule, which contains structures called the utricle and saccule. These have patches of hair cells covered by a gelatinous layer with tiny calcium carbonate crystals called otoliths, literally ear stones.
Ear stones.
Yeah. Gravity pulls on these dense otoliths, bending the hair cells depending on the position of your head. This gives your brain information about linear acceleration and static equilibrium, your head's position relative to gravity, whether you're tilting it or moving straight forward.
So canals for turning, vestibule for tilting, and straight movement.
Basically, yes. It's a very intricate system, all feeding information to the brain to help you maintain balance and coordination. Our source has figures showing these structures clearly.
What stands out to you about common hearing issues, especially thinking about aging?
Well, impaired hearing is incredibly common. It affects maybe 5–10% of the population overall, but that number climbs significantly with age.
Why does hearing tend to decline as we get older?
The most common form of age-related hearing loss is called presbycusis. Our source highlights several reasons in a geriatric considerations box. Degeneration of hair cells in the cochlea, particularly those sensitive to high frequencies, loss of auditory neurons, and decreased blood flow to the cochlea.
And losing high frequencies matters because?
Because that specifically makes it harder to understand speech, especially consonants. So older individuals might say, I can hear you, but I can't understand you, particularly in noisy environments. It's about clarity, not just volume.
Makes sense. How is hearing loss generally classified?
We usually talk about two main types. Conductive hearing loss. This is when there's a problem in the outer or middle ear that impairs sound conduction to the inner ear.
Like what?
Could be something simple like impacted earwax blocking the canal, or fluid buildup behind the eardrum from otitis media middle ear infections, super common in childhood.
Yeah.
Or otosclerosis, where the bones in the middle ear harden and can't vibrate properly.
Okay. Problems with getting the sound in. What's the other type?
This is sensorineural hearing loss. This involves damage to the inner ear itself. the cochlea or the hair cells, or the auditory nerve pathway to the brain.
Damage to the sensing or nerve parts.
Right. Presbycusis is the most common form of this. Other causes include excessive noise exposure, loud concerts, machinery without ear protection, which damages those delicate hair cells. Also, ototoxicity.
Ototoxicity, ear poisoning.
Essentially, yes. Damage caused by certain medications. Some antibiotics, diuretics, chemotherapy drugs can be toxic to the inner ear structures. And then there's Meniere's disease.
I've heard of that. Isn't it about dizziness, too?
Yes, it's an episodic disorder of the inner ear. People experience recurring attacks of vertigo, intense dizziness or spinning, fluctuating hearing loss, tinnitus, ringing or buzzing in the ears, and a feeling of fullness or pressure in the ear. The exact cause isn't fully understood, but it involves an imbalance of fluid pressure within the inner ear.
Sounds very debilitating. Last but not least, for the special senses, let's quickly touch on smell and taste. They seem so linked, don't they? How do they work together to create flavor?
They are absolutely intimately linked. Olfaction, our sense of smell, relies on olfactory receptor cells located high up in the nasal epithelium. These cells can detect thousands of different airborne chemical stimulants, often grouped into primary classes.
Okay. And taste?
A station, or taste, happens via taste buds, mostly located on the tongue but also elsewhere in the mouth. We typically talk about 5 primary taste sensations: sour, salty, sweet, bitter, and umami.
Umami, the savory taste.
Exactly, like the taste of MSG or savory broths. But the perception of flavor is much more than just these 5 tastes. It's the complex interplay between what your taste buds detect and the huge amount of information coming from your sense of smell as molecules travel up the back of your throat to your olfactory receptors.
That's why food tastes so bland when you have a cold and your nose is blocked.
Precisely. Smell contributes massively to flavor perception.
Do these senses change as we age?
Yes, they do. Our sensitivity to both odors and tastes tends to decline with aging.
How significantly?
Our source mentions, in another geriatric box, that a decline in odor sensitivity often becomes more noticeable after age 80. This can impact appetite, enjoyment of food, and even safety, like not being able to smell spoiled food or gas leaks. Taste sensitivity seems to decline more gradually, but older individuals might need stronger flavors to get the same taste perception.
And when these senses aren't functioning correctly, what do we call that?
For smell, a reduced sense is hyposmia, and a complete loss is anosmia. For taste, decreased sensitivity is hypogesia, and absence of taste is agesia. There's also dysgeusia.
Dysgeusia.
That's a perversion or distortion of taste, like things tasting metallic, rotten, or just plain wrong. These conditions can really impact nutrition and quality of life.
Okay, finally, let's zoom out from the special senses in the head to our general body senses. What exactly is somatosensory function, and why is our sense of touch so fundamentally important?
Somatosensory function basically encompasses our sense of touch, pressure, vibration, temperature, which we discussed partly with thermoregulation, pain, which we started with, and also proprioception body position sense.
Let's focus on touch first.
Right. Our skin is absolutely packed with different types of specialized touch receptors. Things like Meissner corpuscles and Pacinian corpuscles, which are good at detecting movement and vibration. Merkel discs respond to sustained light touch. Ruffini endings to deeper pressure and stretch.
A whole toolkit of sensors.
Exactly. They send detailed information about texture, shape, pressure, temperature changes up the spinal cord, through pathways distinct from the pain pathways we discussed earlier, eventually reaching the somatosensory cortex in the brain for interpretation.
Allowing us to feel the world around us, interact with objects.
Precisely. It's fundamental.
And this sense also changes with age, I assume.
It does. While our sense of touch develops very early, even before birth, tactile discrimination, the ability to distinguish fine details through touch, tends to gradually decline with advancing age. And of course, any disruption to these pathways from trauma, infection, metabolic diseases like diabetes can cause tactile dysfunction.
Okay, so touch tells us about the world outside our body. What tells us where our body parts are in relation to each other without even looking?
That brings us to proprioception. It's essentially your body's internal awareness of its own position in movement, your sense of where your limbs are in space, the angle of your joints, the tension in your muscles, all without needing to look.
Like closing your eyes and still being able to touch your nose?
Exactly. That's proprioception in action. It relies on continuous input from receptors in your muscles, muscle spindles, tendons, Golgi tendon organs, and joint capsules, as well as input from your inner ear's vestibular system for balance.
And why is this so critical?
It's absolutely vital for coordinated movements, maintaining posture and balance, fine motor control, basically interacting effectively and safely with the environment. Imagine trying to walk or pick up a glass if you had no idea where your feet or hands were unless you were constantly watching them.
Impossible. And what happens when proprioception is off? Does it also decline with age?
Yes, a progressive loss of proprioception is commonly reported in elderly persons. This contributes significantly to postural instability and increases their risk for falls and injuries.
So problems with proprioception can lead to balance issues.
Definitely. Dysfunctions can manifest in various ways. We mentioned vertigo earlier. That sensation of spinning, often from inner ear problems, directly impacts your sense of balance and position. There's also vestibular nystagmus, those involuntary eye movements, which can occur if the inner ear balance system is overstimulated or damaged.
And other conditions can affect it too.
Yes, peripheral neuropathies are a big one. Nerve damage, often seen in conditions like diabetes or kidney disease, can severely impair the sensory feedback from the feet and legs, diminishing that sense of body position and leading to unsteadiness and changes in gait. Hashtag outro trap.
Wow, what an incredible deep dive today. We've really journeyed through some fundamental aspects of how we experience and navigate the world. From the intricate dance of neurotransmitters and pain,
To how tiny structures in your inner ear keep you balanced, how your hypothalamus acts as a thermostat, the mysteries of sleep cycles.
it truly highlights the sheer complexity and really the interconnectedness of our bodies, and also how easily these systems can be affected by illness, injury, or simply the process of aging.
Absolutely. And if we connect this back to the bigger picture, understanding these basic pathophysiological mechanisms, how things work and how they can go wrong at this fundamental level, is so crucial for appreciating the vast array of clinical signs and symptoms we see in health and disease.
Yeah, it really underscores how fundamental these senses and regulatory systems are. They're working silently in the background most of the time until something disrupts them.
Exactly. We often take them completely for granted.
So reflecting on all this, what stands out to you? Maybe it's that idea that your brain is actively modulating your pain signals, turning the volume up or down.
Or perhaps the surprising idea that a moderate fever isn't always the enemy, but can be a sign of an effective immune response.
It really makes you think about your own body in a new way, doesn't it?
It does. And maybe this raises a final question for our listeners to ponder. How might a deeper personal understanding of these sensory and regulatory systems empower you to better advocate for your own health and well-being, or understand the experiences of others?
That's a great question to leave things on. Thank you so much for joining us on this deep dive into the fascinating world of pain, temperature, sleep, and sensory function, all based on Chapter 15 of Understanding Pathophysiology.
We hope you feel more informed and maybe even more intrigued by the amazing mechanisms at play within your own body.
Until next time.